Good evening. I'd like to welcome you to our Treatment Options for BPH webinar presented by Jay Paddack, MD. Thank you for joining us. Dr. Jay Paddack joined Colorado Urology in November of 2019 and has been practicing general urology in northern Colorado since 2014. He treats adult patients for general urologic conditions and specializes in BPH and male sexual dysfunction. Dr. Paddack received his Doctor of Medicine degree from Texas Tech University Health Sciences Center in Texas, where he was inducted into the prestigious Alpha Omega Alpha Medical Honor Society. He then completed both his general surgery internship and urology residence at the University of Arkansas for Medical Sciences in Little Rock, Arkansas. Dr. Paddack is certified by the American Board of Urology and is a member of the American Urological Associations. I'd like to welcome Dr. Jay Paddack.
Thank you, everybody who's joining us tonight. As Jennifer already said, I'm a urologist. I practice in Longmont, Colorado. Among other things, I do specialize in the treatment of BPH. Tonight, we're going to cover just a general overview of the prostate and what it is and how it functions and what it does. We'll talk a little bit about BPH in general and how it causes issues, and then we will go into possible treatment options. So what is the prostate? Well, it's a small gland, the base of the bladder. It's about the size of a walnut. The urethra, the channel that you urinate through, goes right down through the middle of it, and it's involved in sexual function. It produces the semen fluid that transports sperm during ejaculation. It grows to its normal size in a man's early 20s, but then it starts growing again beginning in the mid 40s and on, and that's where some of the issues related to that can start. There are multiple issues that can affect the prostate. What we're talking about tonight is prostate enlargement. Prostatitis is another condition. It's an inflammatory, sometimes infectious condition that can affect the prostate. Most of us are aware that prostate cancer is also a common malady involving the prostate. And that's also an important part of the evaluation when you do come see your urologist about some of these issues. We're talking about BPH. So it's a benign, non-cancerous condition. It refers to the enlargement and the increase in the production of cells over the normal number that happens with age. BPH itself is not necessarily a problem. The problem really happens when it leads to obstruction of the bladder and the resulting lower urinary tract symptoms that can result from that. What is the relation between BPH and prostate cancer? It's a separate issue. It's BPH is not prostate cancer, does not cause prostate cancer. Sometimes the symptoms of BPH and symptoms of cancer can present in a similar way. You can actually have both of the conditions at the same time as well. The main test that we use to screen for prostate cancer is the PSA, or prostate-specific antigen blood test. These alone don't distinguish BPH from prostate cancer. They can both cause elevated levels in the blood. Part of the evaluation process when somebody comes into the clinic, especially in a man with particular symptoms and of a certain age, does involve screening for prostate cancer as well. What specifically is happening with this issue? So you can see right here, this is basically a normal sized prostate, normal caliber urethra as it goes down through the prostate. Over here you see this enlargement of the prostate, and what's going on is it pinches off, it compresses the urethra as it goes through the prostate and obstructs the flow. This resulting obstruction leads to urinary symptoms. And it's also important to note that the size of the prostate does not necessarily correlate with the symptoms. So you could have a prostate that really is about this size on the outside, but it can still cause obstruction through as the urethra goes through the prostate. And you can have a prostate that's this size, but it's not really causing any significant symptoms. So the correlation is not direct. So when we talk about these symptoms, what are we talking about? It can be frequent urination, either daytime or at night. At nighttime, we call that nocturia. It can include the sudden urge to urinate where you have to run to the bathroom. It can include some discomfort with urination, weak stream, the sensation that there's still something left in the bladder after you finish urinating, urinary hesitancy, which is difficulty starting and stopping the urine flow, and in severe cases, the inability to urinate altogether. How significant is this problem? Up to 95% of men with significant symptoms state that they're not not satisfied with this. They don't want to spend the rest of their lives with these symptoms, and they want to do something about it. 51% of these men, they say that it interferes with their daily lives, their daily routines. A similar number also experiences some significant sexual issues associated with their urine issues. And then finally, it's not just an issue of men themselves. It can affect partners, spouses, and personal relationships as well. Who does it affect? Who can get this? So it's the most common thing that we see in our clinic, and especially in men starting at age 50 and beyond. The percentage of people that it affects correlates directly with age. So about 50% roughly of men by age 60 have some degree of symptoms. And then when you get up to 85 and beyond, it's the vast majority, up to 90% of men. So it really does affect a large portion of men. So how many is this overall? So back in 2010, it was estimated about 14 million men had some degree of these issues. Well, 10 years later, and our population is aging, and certainly these numbers are higher. Some other factors that can influence the symptoms and the likelihood of having BPH is obesity, an elevated body mass index, and also decreased levels of activity. What do we do to diagnose prostate enlargement? Well, it's an in-person evaluation here in our clinic. We take a comprehensive history. We ask about these symptoms, how long they've been going on, how severe they are. Sometimes we use some questionnaires to help better quantify it. We do a comprehensive examination. This includes a digital rectal exam to just gauge the size of the prostate, feel to see if there's any abnormalities. We do urine testing, including a urinalysis. We sometimes measure urine flow. We measure what we call a post-void residual, which is measuring the amount of urine that remains in the bladder after completing urination. Sometimes we also do some additional procedures. Cystoscopy is a procedure where we look into the urethra and the prostate and the bladder with a flexible camera. Let's go ahead and get into the treatment options. When we're looking at when we're talking about our approach to treating BPH, we always start from the least invasive intervention and proceed in a stepwise fashion from there. This begins with basic behavioral modifications, maybe as simple as some fluid and dietary changes. We refer to this as watchful waiting. Essentially, this being the symptoms aren't that severe. They don't significantly affect quality of life to the degree that the particular patient wants to do anything. So we watch it. The next kind of first line therapies, this includes medications. The most invasive procedures are more surgical, done in the operating room. A couple of the procedures that we're going to talk about tonight, including the Rezum therapy and these implants, these fall into this first-line therapies. These are some newer, exciting treatments because for a long time there's only medications that fell into this realm. So these are sort of bridging the gap between people that don't necessarily want to be on medications, but don't necessarily want to go with any surgical procedures. Quick statement on some alternative medications, supplements, things like that. We get asked a lot about saw palmetto and some other things. There's not a whole lot of strong data that these help, especially in men with more severe symptoms. So it's not a big part of our treatment for this condition. First option, watchful waiting. And what is this? It's essentially just monitoring the symptoms, monitoring certain lifestyle things like diet, fluid intake, decreasing fluid intake in the evening, possibly decreasing caffeine, alcohol intake at certain times of the day. The benefit of this is, well, you don't have to take a medication. You don't have to have a procedure done. It works for a number of people. About 20% of people are satisfied with this. Now, what's the downside of this? Well, the symptoms can get worse. Over time, they can worsen at the point where you may decide you want to pursue some sort of treatment. I'd say in extreme cases and in rare cases, sometimes if you do delay treatment too long, sometimes your options become limited down the road. Going into our first line therapies is medications. The most common medication that we start with is called an alpha blocker. There's a number of these. You may have heard of Flomax, Rapaflo, Uroxetrol. This is a lot of times our first step. How do these work? Well, this is a daily pill. It helps to relax the muscles at the bladder, neck, and as it goes through the urethra and helps open that channel, allowing the urine to flow more freely. So this is, for a lot of people, an effective an effective option. It controls the symptoms. It's a daily pill, and people are happy with that. There are some potential downsides to this. Side effects. Every medication has the potential of having a side effect. This can include blood pressure changes. This can include dizziness when you stand up too fast, drug interactions with other medications, and there also are some potential sexual side effects. Although this can work well, the reality is a lot of men aren't compliant with this. It's because of the side effects, or it's just hard to take a daily pill. So another medication that we use sometimes in conjunction with the alpha blockers, or also by themselves, are called 5-alpha reductase inhibitors. So these medications, there's a couple: Proscar, finasteride, dutasteride. These work by basically arresting the growth of the prostate and actually shrinking the prostate to some degree. And this works by decreasing the production of a hormone called DHT, controlling the symptoms with a pill, a daily pill, avoiding a procedure potentially. Again, potential side effects of the medication. These particular medications can affect the PSA levels. They can lower the PSA up to 50%, which is only an issue if there's any concern for an underlying prostate cancer, because that can sort of confuse the diagnosis of that. Some potential sexual side effects, including erectile dysfunction, decreased libido, retrograde ejaculation. If you're not sure what that is, it's actually, so what happens is during ejaculation, the semen actually goes backwards into the bladder rather than going the forward direction. The next couple things I'm going to talk about are these minimally invasive office-based procedures that are now also considered in this first line of treatment. Rezum is a treatment that uses heated water vapor essentially to shrink the benign prostatic tissue. It's non-surgical. It's done in the clinic under local anesthetic. We've had some good success with this. The retreatment rates are low. A lot of good outcomes from this. Like anything, it's got potential side effects. Typically, these are temporary side effects, some discomfort with urination, limited urinary frequency, mild blood in the urine and the semen, blood for less than that, semen for up to a few weeks. So how does this work? Here's a diagram of the enlarged prostate here. So this is administered through a scope, lighted camera basically that goes up into the urethra as it goes to the prostate. It injects steam throughout the prostate. Over time, typically a period of 1 to 3 months, this tissue will sort of shrink away and result in a wide open urethra like that. So like I said, there's been some good results with this. One study looking at about 250 patients that had this done showed about a 97% patient satisfaction rate. People are generally happy with the outcomes of this. Another option, sort of in this same realm, is called the prostatic urethral lift. You may have heard of the UroLift. That's what this refers to. Again, it's a non-surgical outpatient procedure. It utilizes implants basically to suspend the enlarged tissue and sort of pulls the tissue out of the way to result in a open urethral channel. Benefit of no general anesthesia. It's done under local. It does involve an implant. Again, positive outcomes, low surgical retreatment rates. Temporary side effects, similar, some discomfort, some mild pelvic discomfort over a couple of weeks, blood in the urine, some frequent urination, and rare cases of stone formation. Sometimes these first line treatments just aren't the right treatment, or they don't work for a particular patient. And there still is definitely a role for these little bit more invasive surgical procedures. So one option that we've had success with is the green light laser. And this is a surgical procedure. It's done under anesthesia. It's outpatient. What it does is uses laser as an energy source to vaporize the prostate tissue and open that urethral channel. It is done under general. The success rates of this are also quite high, really good 5-year success rates. Similar side effects, temporary pain while going through the healing process, blood in the urine, urinary retention, essentially where you can't empty your bladder and it requires a temporary catheter, is a rare side effect, as is urinary tract infection. So this is a diagram explaining how this works. So again, you have your enlarged tissue here. And again, this is administered through a scope through the urethra. And what it does is it vaporizes the tissue through the prostate here, resulting in this wide open channel. Another kind of similar type of procedure is called the Transurethral resection of the prostate, or TURP. This is sort of the treatment by which all all other treatments are compared to, just because it's been a successful treatment for a long time. It's a surgical procedure, outpatient, sometimes overnight, stay in the hospital, that uses, rather than a laser, uses a heated wire to cut the tissue away from the prostate. Really good 5-year and even out to 10-year good surgical, low surgical retreatment rates, rather. Similar side effects, some discomfort, slightly higher risk of bleeding. It does sometimes require an overnight stay just to monitor the urine drainage and monitor for any bleeding or anything like that. Low risks of urinary tract infection and retention. The last surgical treatment option to cover is called the prostatectomy, suprapubic prostatectomy. This is probably our most invasive procedure. Some people just are not candidates for these minimally invasive procedures or these other surgical procedures, just based on the sheer size of their prostate. If somebody's got a prostate over a certain size, this is just what needs to be done. And what this involves is it's done through incisions in the abdomen, usually laparoscopic. I do this using the Da Vinci robot. And what we do is we go in and we remove the inner portion of the prostate and leave the outer capsule. So by removing that inner portion, it results in a wide open urethra. A little bit more invasive procedure, although we do use minimally invasive techniques. The surgical retreatment rates are very low. It's a highly successful procedure, but at the trade-off of being a little bit more invasive, a little bit higher risk of bleeding, rare risks of sepsis, and it is more likely to cause some sexual side effects. So that's something we encourage you to look into, and we can also assist with that. We have resources to help with that in our clinic as well. So just a kind of a quick summary. Hopefully you have a little bit better idea of where the prostate is, how it works, how it can cause problems specifically as it gets larger with age. We covered treatment options ranging from watching, doing no active treatment, to the first line therapies, either medications or these minimally invasive, exciting newer treatments that don't involve having to go to the operating room. There being a place for these surgical procedures in our armamentarium. Hopefully this is informative. The next step is to come on in and have a discussion, have an in-person evaluation, and talk about what treatment is right for you. And I'd love to answer any questions that anybody might have.
Dr. Paddack, first question is, if both Rezum and PUL cause frequent urination, and this is my issue, why would I want to try this Rezum procedure?
Without knowing exactly what is causing the frequency, a little bit difficult question to answer. It would be good to have an in-person evaluation, check a few of these things, urinalysis, check to see how well the bladder is emptying, check the prostate. If this truly is related to BPH, the point that I want to make about these procedures is the frequency that they result in is typically a temporary temporary symptom, usually as a result of just some irritation from the procedure itself. And after this period of frequency, we typically find that the baseline frequency that you were having gets improved significantly.
Do you have any early returns from the Rezum XL study?
I do not have that information with me at the moment, no.
Can you go over the complications of the Rezum procedure one more time, please?
Most of the side effects of these procedures, they're fairly similar. Some mild, kind of self-limited discomfort, frequent urination over a short period of time. Because initially there's some more swelling, the symptoms can temporarily get a little bit worse before they get better. Mild bleeding for a few days are the typical symptoms we see.
Is there a benefit to taking both finasteride and Flomax at the same time?
Yes, it's actually a fairly common strategy that we use. And a lot of times we'll start with one or the other. A lot of times we start with the Flomax. Hopefully that gives some benefit, but depending on the degree of improvement, we a lot of times will add the second medication. And a lot of times the finasteride it's the most beneficial in men with a certain size prostate. So I mentioned that even men with a small size prostate can still have the symptoms. It doesn't work as well because we're already starting with a pretty small prostate. the effect seems to be more dramatic when you start with a little bit larger prostate.
Does the green light laser treatment cause retrograde ejaculation?
It can. I would say any of these, the surgical procedures, whether it be a suprapubic prostatectomy, the TURP procedure, or the green light procedure, because they're removing a larger portion of tissue, they all have that potential. I would say the potential is lower for green light, a little bit higher for TURP, and then highest for prostatectomy.
Does the scope provide enough information so that I can choose a best option?
Sometimes yes. Sometimes that's all we need to do. Sometimes we do additional evaluations. That includes if there's a question about the size of the prostate. Sometimes we'll do an ultrasound to get a better objective volume measurement of the prostate. Sometimes if there's also some complicating factors, say somebody with diabetes or other conditions where we're not 100% sure that the symptoms are related to the prostate, we'll do a study called urodynamics. Basically tests the function of the bladder and can actually tell us if this is an obstructive issue or something else.
How are PSA levels affected after the Rezum treatment?
That's a good question, and I don't know that we fully know the answer to that. Typically with most of these procedures, because you are removing a portion of prostate tissue, we do expect the PSA level to go down to a certain extent, and usually we sort of establish a new baseline PSA for each individual. We continue to, it's still an important thing to continue to monitor.
My urologist says my prostate is 60% larger than normal and ejaculation is mildly painful. Am I causing trouble by continuing to have sex?
No, I don't think so. I don't think there's really any negative effect of that. It's a matter of how much it's bothering you and how uncomfortable it is.
I believe the least invasive method is to drink less liquid after 6 p.m. Do you have any related suggestions that are simple?
That's one of the best ones that we have to suggest. It's a fluid intake in the evening and the type of fluid. Caffeine, alcohol, spicy foods can tend to be an irritant to the bladder. So definitely getting your fluid intake earlier in the day is probably the best behavior modification you can make.
And what type of diet changes might be beneficial?
I think fluid intake is the most important thing. I kind of alluded to it, that certain dietary things can irritate the bladder, not necessarily make the prostate enlargement worse, but worsen the symptoms just in terms of their ability to increase frequency or the urge to urinate. Spicy foods, acidic foods, processed foods can all contribute to that.
My doctor has diagnosed my prostate as large and my PSA is high. Do I need an MRI in order to have the Rezum procedure?
Without knowing the details of that, I wouldn't say you need an MRI necessarily, but we definitely, if there's any concern for an underlying prostate cancer that has not been evaluated, that's always the priority. If it's rising, if it's concerning, or if the exam is concerning, sometimes that involves doing a biopsy beforehand. MRIs are a useful tool. Typically, those are used, at least in my practice, more as a second line evaluation for prostate cancer. Usually after an initial biopsy that was negative, but the PSA continues to rise, and there's maybe a concern that there might be an underlying cancer there. That's typically how I tend to utilize the MRI.
If I'm taking tamsulosin with milder symptoms, would you suggest a new medication before trying a procedure?
It depends. It all depends on the severity of symptoms. So if you've had success with the tamsulosin but still having some residual symptoms, one option might be to add finasteride and see if that gives you some additional improvement. Then again, it just becomes a matter of would you prefer to take medications, in which case, yes, that would be a good option. Or if you wanted to potentially deal with this with a procedure and with the goal of not having to take a medication. So there's a couple different ways you could approach that.
For the green light laser surgery, can you explain the sexual side effect?
Essentially what we're doing is because we're creating a defect between the bottom portion of the prostate and the bladder, the semen is expelled towards the bottom of the prostate. Now, if that tissue were not gone, the semen would be expelled forward as it normally is, because it basically takes the path of least resistance, which is backwards into the bladder. Those are the most common sexual side effects. Now, there are very rare issues with erectile dysfunction, which in which case it's more probably a nerve issue, but that's, in my experience, that's a less likely complication.
We have several questions about the lifespan of the Rezum treatment, if it's something that will have to be repeated after a certain length of time. Can you speak on that?
Yeah, that's a good question, an important point. It is a newer technology. We have good 5-year data right now, so that's really all we can speak on. One of the reasons the TURP procedure is still an important procedure is because it has good long-term results, and why these surgical procedures still exist, because a lot of people, it's important for them to have one procedure and be done with it. And that's a possibility with the Rezum, certainly. We just don't have the data to say it's good at 10 years. If and when we do have that data, that will be very important. That being said, some people are at a certain point in their life, they want relief, they want a procedure to relieve the symptoms, and they don't want the more significant side effects that come with the surgical procedure. So the good news is not that we go in planning on this, but there aren't any real bridges burned if you do the Rezum procedure and down the road you need to have something done again.
Can you talk a little bit about the green light therapy versus the Rezum procedure, please?
The most basic things, the Rezum, now they're similar. It's done through the urethra. You're removing prostate tissue just using different energy sources. The Rezum is done in office. It takes less than 10 minutes. It's done under local anesthesia. The green light is done in the operating room under anesthesia. It takes typically 60 to 90 minutes. And those are kind of the big differences. It's just a little bit more invasive, a little bit more. The bleeding risk is low with both of them, but a little bit higher bleeding risk. Those are the main differences.
I am a heart patient. Are there any limitations involving the enlarged prostate medication?
It depends. It definitely depends on what the particulars of your heart disease. We have a lot of heart disease is a very common issue with this same patient population. So a lot of times, you're still able to take prostate medications even with your underlying heart issues. One additional thing I would mention is just in general, patients that are on blood thinners, sometimes these less invasive options are good options where before they didn't really have a good option. So the green light laser or these office-based procedures are sometimes good options for those patients.
Can these less invasive surgical procedures be done if a prior TURP procedure has failed?
Depending on how the prior TURP procedure has failed. If it's purely an issue of regrowth of the prostate, and that does happen, then yes, I would say that would be an option to try one of these things first, especially if you wanted to avoid the more invasive procedures.
Do any of these procedures have an impact on cancer development, prostate cancer development?
Not that we're aware of. There's no data that suggests that there's any increased likelihood of prostate cancer if you have one of these procedures done.
Can you please compare the Rezum and UroLift procedures, please?
So both local anesthesia done in the office through the urethra. Both take a similar amount of time, less than 10 minutes. Using steam injected into the prostate throughout the prostate is how the Rezum works. It then over a period of 1 to 3 months, that tissue sort of shrinks away. UroLift is done by deploying these implants that suspend. We're not removing tissue. It just suspends the enlarged prostate tissue out of the way. Just two different ways of opening that channel. Sometimes one person's a better candidate for Rezum, one person is a better candidate for UroLift. There's not really there's a place for all of these. Patients with particular anatomy, one thing in particular, it's called a median lobe that grows up into the prostate. At least in my opinion, those patients are better candidates for Rezum because it's harder to get that tissue out of the way using the other procedure. Depending on the individual, there's a place for all of these.
Can you speak to the increased risk of aggressive prostate cancer with dutasteride?
Yeah, that's a good question. The initial study on that did show that there was an increased diagnosis of higher risk, more aggressive prostate cancers as a result of this medication. Subsequent analysis then kind of showed that was probably not the case. What the idea is, what's happening is, since the medication is shrinking down the prostate, when you do a biopsy, you have less real estate to biopsy, so you're more likely to hit an area of of higher grade prostate cancer. Whereas if you weren't on one of these medications and the prostate was larger, that cancer was probably there all along. It was probably just less likely to be discovered.
I have retrograde ejaculation and a decreased sex drive since taking tamsulosin. Would Rezum help with either or both?
Potentially, it sounds like there's different things that can cause those issues, but that certainly can be a side effect of that medication. So potentially as an alternative and a way to get off that medication, that might be a good consideration to pursue.
There's several questions about medications that are no longer working effectively and what the next step would be when that happens. Can you speak to that?
Would definitely recommend in-person evaluation. Check the symptoms, check to see if there's a significant residual in the bladder. Now, a lot of times I like to start as a next step to see if somebody's a candidate and to really confirm that this really is a prostate issue is a cystoscopy. It's a really beneficial procedure to really just get a lay of the anatomy and know exactly what's going on in there. So that's typically how I like to proceed.
Can you say what you've heard about whether or not finasteride enlarges male breasts?
It's a rare side effect, but it's a real side effect. It does, or it can cause that. It does affect the hormones and can result in higher levels of estrogen actually and breast formation and breast tenderness.
I have conflicting information about how effective Rezum is with an intravesical lobe. Do you know how effective a Rezum procedure has been with this condition?
It is, and this is according to our American Urological Association guidelines. If we're speaking about the office-based procedures, it is indicated for men with an intravesical lobe. It does have the ability to treat that, in addition to the surgical, the more invasive surgical options. But if you're looking for an office-based procedure that can successfully address that type of anatomy, the Rezum might be your better option there.
If I've had the test already and I'm a current patient, do I need to have the urine test again?
I'm not sure exactly what urine test you're referring to, whether it be a urinalysis or urodynamics or a residual check. Not necessarily. I don't, without knowing more specifics, it's hard for me to answer that question.
He said urodynamics, the very unpleasant one.
Okay. I would say most likely not. If it was done relatively recently and the symptoms aren't dramatically different or there aren't any major changes in your health, then I think that could probably be deferred.
Okay, so thank you for those great questions and again for joining us. If your question was too personal and too specific, I apologize that we're not able to answer them on the webinar, but you can get those questions answered by giving us a call at Colorado Urology. You will be receiving a follow-up email with a link to this presentation video, and you'll also be able to find the video on our website at coloradourology.com or on our YouTube channel. Colorado Urology's 11 offices are now open for in-person appointments, and our physicians are also taking telehealth appointments. Please visit coloradourology.com for more information or to schedule an appointment. Thank you very much for being with us, and here's to the best of health.